Good morning, good afternoon, good evening, everyone, and most welcome to today's digital event, AI in Clinical Practice, from Insight to Intervention. We are thrilled to have you join us as we explore how AI is and can be used in pharmacy practice. This is the fourth session organized by the International Pharmaceutical Federation and our technology advisory group under the theme of the promise of AI in pharmacy practice. Next slide, please. My name is Lars-Åke Söderlund, and I am the chair of the FIP Technology Advisory Group and immediate past vice president of FIP. As artificial intelligence, AI, becomes increasingly embedded in clinical decision-making, its impact on pharmacy practice is both profound and transformative. Clinical pharmacists are now leveraging AI tools to enhance therapeutic decision-making, optimize medication management, and deliver more personalized, patient-centered care. And today's event explores how AI-driven insights can be translated into effective clinical interventions, improving safety, efficacy, and outcomes across diverse healthcare settings. Next slide, please. As you can see on this slide, we have some announcements to make before we start the event. Please note that this event will be recorded, live streamed on FIP YouTube, and the recording will be available at events.fip.org. To all those listening, please feel free to send your questions through the Q&A box provided, and I will do my best to manage all the questions so that at the end we will be able to address those questions. And you are, of course, very welcome to provide feedback to webinars@fip.org, because that makes it possible for us to improve future digital events as well. And I would like to take this opportunity to promote the benefits of membership with FIP, including events and webinars. FIP is the global body representing over 5.5 million pharmacists and pharmaceutical scientists. And if you are a pharmacist or a pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. Next slide, please. Yes. We now have a new feature in Zoom. You can actually get translations to your own language, and this is how you do it. Turn on captions according to the slide here. Enable the translation toggle. Choose your preferred language under My Caption Language. And now you can actually follow along with live translated captions. Next slide, please. Here you can see today's program. We have 3 presentations: empowering pharmacist-led risk management with AI, from patient-level assessment to system-level monitoring; social robots and digital humans, elevating the human experience for patients; and AI-assisted clinical decision-making for improved medication safety. Next slide, please. The learning objectives for today's events are: understand how AI technologies are shaping clinical pharmacy practice and enhancing evidence-based patient-centered care; evaluate the application of AI tools in therapeutic decision-making, medication optimization, and risk prediction; develop strategies to integrate AI-derived insights into clinical interventions while maintaining professional judgment and ethical standards; and critically assess the challenges, opportunities, and outcomes of AI-assisted clinical pharmacy practice, focusing on improving patient safety and therapeutic efficacy. For this event, we are joined by a panel of fabulous speakers, and I want to sincerely thank each of them for taking the time to prepare their presentations. And with us today are Kanita Duangyamkarn, School of Pharmaceutical Sciences, University of Payao in Thailand; Dr. Bob van den Berg, Lead Creative Technologies from Deloitte in the Netherlands; and Dr. Tora Hammar, Associate Professor in Health Informatics from the Linnaeus University Department of Medicine and Optometry in Kalmar, Sweden. A warm welcome to all of you, and thank you for making yourself available for today's event. The FIP development goals launched by the International Pharmaceutical Federation in September 2020, are a key resource for transforming the pharmacy profession over the next decade globally, regionally, and nationally. And they align with FIP's mission to support global health by enabling the advancement of pharmaceutical practice, sciences, and education, and are set to transform pharmacy in alignment with wider global imperatives underpinning the UN Sustainable Development Goals. And they now also align with our work and inform our direction towards 2030. And as such, they are also an important part of the new FIP strategic plan towards 2030. The digital health development goal is a high priority for our profession nowadays. And the FIP development goal on digital health emphasizes integrating digital technologies into pharmacy practice to improve patient care, strengthen health systems, and build pharmacists' digital competencies through education, infrastructure, and supportive policies. And linked to this development goal, we aim to have a workforce and education strategies that focus on building digital health competencies, enabling pharmacists to use digital tools and data to improve patient care and health outcomes. We aim to have digital health technologies integrated into pharmacy practice to enhance medication safety, optimize workflows, support decision-making, and expand patient access to care. And finally, we aim to make sure that the advancement of digital health science promotes evidence-based use of technologies, ensuring data security and interoperability, and driving innovation in pharmaceutical care delivery. Next slide, please. And for more information and resources on digital health, please visit our dedicated microsite, as you can see on this slide, or scan the QR code on this slide, which will lead you directly to the microsite. Next slide, please. As mentioned earlier, this event, together with 3 other events, are organized by FIP's Technology Advisory Group. This is the 4th event in this series of events, and by scanning the QR code to the right, you can sign up for a newsletter for new exciting digital events linked to AI and other important areas for our profession. Next slide, please. Thank you. It is now my great honor and pleasure to introduce our first speaker, Dr. Kanita Duwangyamkarn. She is a lecturer at the School of Pharmaceutical Sciences, University of Phayao, Thailand, and executive member of the FIP Technology Advisory Group. With a PharmD and a PhD in biomedical engineering, she bridges clinical pharmacy and engineering to advance healthcare solutions. She leads the CaterX research group, focusing on AI-enhanced pharmaceutical care, predictive modeling for high-risk diabetes management, and AI-driven pharmacovigilance. And her work includes developing frameworks for adverse drug reaction signal detection and supporting national medical AI regulation within Thailand and together with the Thai FDA. Welcome, Kanita, to give us your presentation on empowering pharmacist-led risk management with AI, from patient-level assessment to system-level monitoring. Welcome.
Thank you very much, Lars. Thank you very much for a lovely introduction. Sawadee ka, and warm greeting to everyone. I am Dr. Kanita Duwangyamkarn. Today, I want to talk about shifting our perspective. Well, I know that today we often hear about AI as a tool for efficiency, but today I want to propose that this is our most powerful tool for the risk management, especially in healthcare. And I will take you through our journey in Thailand, showing how we are empowering pharmacists to move from patient-level assessments to the system-level monitoring. And to give you some context of my perspective, I know Lars already introduced, I stand at the intersections of 2 disciplinaries. So I hold PharmD in pharmaceutical care and also PhD in biomedical engineering. And besides a privilege of serving on FIP Technology Advisory Group and work with Lars, I am also representing pharmacist practitioners in the IEEE Engineering, Medicine and Biology Society, which is the world's largest biomedical engineering society. society. So my work is dedicated to translating complex engineering code into practical clinical care. And now, with this slides, let's start with the reality on the ground. Thailand is actually a well-known success story for universal health coverage. So 99% of our population has access to healthcare. But somehow this success brings a massive challenge, the constraint. So we have high patient demand, but a limited number of specialists, especially in the rural areas like my province in Phayao, or even in a big city like Bangkok. So our philosophy is simple. AI is not a luxury, it's a necessity for equity. So we use it to bridge the gap between the huge demand for service and the need for personalized care. Next slide, please. So how do we build that bridge? So this is the role of my research group at the Computational Application and Translational Engineering in Pharmacy. We act as the integration engine. On the left, we have the hard science, engineering solutions, computational intelligence. And on the right, we have the clinical reality, patient care, and the public health policy. So our job is the translational process in the middle. So we don't just build the model, we build the workflows that pharmacists can actually use. Next slide, please. So our mission is to connect research, clinical practice, and regulatory frameworks to improve the medication safety, optimize therapeutic outcomes, and ensure equitable healthcare access. So we focus on three levels of implementation. Today, I will walk you through three specific levels where we are applying this engine and a project that we are currently working on. The first one is the clinic level. So we're using the computational approach for the NCD triaging. So this one is actually ongoing, and we work with the DM outpatient clinics. The next one is the national level. We're scaling up the AI to big data in pharmacovigilance with the Thai FDA. This is a huge and the challenging one, and it's still ongoing. The next one is the educational level. We preparing the next generation, our student, our pharmacists, through the senior project on generative AI. Actually, for this part, I really have a lot to share, and we will see it on the last session of my talk. Next slide, please. So let's start with the first one at the clinic level. Right now in Thailand, we have over 6 million diabetes patients and 300,000 new cases every year. So the crisis is that we often treating the numbers, focusing on blood glucose levels with overlooking the risks, specifically the heart failure. So type 2 diabetes patients have like 2 to 5 times higher risks on heart failure. So if we wait for the symptoms, it's often too late. So we need to treat the patient, not just the numbers, not just the glucose reading. Next slide, please. So to address this gap, we adopt the Watch DM. This one is actually a ready-to-use scoring-based approach recently published in a scientific report in 2024. So we took this validated model, we computerized it, and we integrated directly into our outpatient diabetes clinic. The system is now act as a background screener. It processes the routine input data like age, BMI, creatinine, the QRS duration, the plasma glucose, and then we automatically flag patients who are at moderate to high risk of heart failure. However, the algorithm here will be useless without a pharmacist though, because when the computer flags this risk, it will trigger a pharmacist intervention at the outpatient clinic. We will then immediately initiate specific counseling on sodium intake, crucially review the patient prescription, especially for the SGLT2 inhibitors, to reduce additional risks of heart failure. So for this project, we are moving from reactive care to proactive prevention, and it's actually like going good right now. And we hope to publish it in some conference, probably FAPA in Thailand this year in November. Next slide, please. And the lesson that we learned from this project is actually vital. I would say the success isn't about the algorithms. Complexity is about the integration. So Watch GM isn't the most advanced AI in the world, but is a ready-to-use scoring-based approach that fits our workflow. So it allows the pharmacist to step up as a primary risk manager, minimizing costs and preventing complications before they manifest. Next slide, please. And now we're moving into the pharmacovigilance. So this one, we are working with the Thai Food and Drug Administration in detecting the ADR signal in a medication. So we scale up from one hospital to the entire country. We're collaborating with Thai FDA. And the challenge for the pharmacovigilance, actually, I would say globally around the world, the challenge is the volume of the data and the noise. So the Thai database is actually the same as in every country. We receive thousands of spontaneous reports. Human experts cannot manually review every single one in real time. Like in Thai FDA, we have probably like thousands submissions daily. And for traditional statistic that we use for the pharmacovigilance, somehow we struggle because the data is messy, is underreporting, duplicates, and incomplete fields. So we face the positive level challenge because if the adverse drug reaction isn't reported, it doesn't mean the drug is safe. It just means the data is unlabeled. It just means the data is just underreported. Next slide, please. And to solve this, our research team developed a new model to combine the reinforcement learning with a positive unlabeled framework. So this might sound a little bit fancy and a little bit complicated. Unlike traditional methods that are reactive, our AI proactively hunts for hidden patterns within the database, looking for unlabeled or underreported ADR signals. And we're trying to find those signals. So the results are promising, though, actually, because our method achieve 95% recall, significantly outperforming traditional supervised learning in detecting early warning signals. Next slide, please. We can now discover the new ADR signal for each drug faster and smarter, and that helps the Thai FDA to prioritize the experts' time on the signal that truly matters. And with that, we all know that not all of the pharmacy know the generative AI. Not all of the pharmacy we have the foundation of AI. So in our university, in our school, we trying to train our student. So we call it in our school generative AI smart use. So we're trying to prepare our digital native pharmacy student for the future. They know about AI, they know the generative AI more than we do, I guess, but they have to use it smart. So at our university, we integrate AI literacy directly into the pharmacy curriculum via senior projects. So we want to test if AI is ready to work without supervision. So our research revealed two critical warnings, though. The first one, the specialist fallacy, if you see it from the graph, we found that a specialized medical AI somehow actually performs significant no better than general AI like ChatGPT-4 on compounding tasks or on like simple healthcare question answer things. And the second one, the failure of prompt engineering. We attempt to use fancy prompting technique like few shot prompting by giving the AI example or prefer format answer to improve performance. Surprisingly, it degraded the performance somehow by like 3.5 points out of 10 in drug interaction checks. And this proved that specialized levels and complex prompts are not guarantees of safety. So this is the one that we try to tell our pharmacy student all the time that you cannot believe everything that generative AI says. Next slide, please. So the evidence here, it leads us to our core educational philosophy. the pharmacist in the loop framework. Actually, the pharmacist in the loop framework is widely used right now. So we teach our students that they are not just users. They are mandatory safety firewalls. So the workflow here is, I would say, is strict for our student. First one, where you get the input, like the health queries comes in like from nowhere, from everywhere. Then you can use the AI to process the question. The AI can act as a clinical intern. They can draft the response and potential signal can be identified. And then here comes the loop. This is a critical step. So the pharmacists have to audit the output against primary literatures and patient contexts. Only after this verification complete, we will then deliver the outputs. We are shifting the skill sets of our students from retrieving information to auditing intelligence. Next slide, please. And here in summary, from data entry to data strategy, AI is helping us move from data entry to data strategies, as mentioned. In the clinic, we are managing rates, moving from treating numbers to preventing heart failure in our DM outpatient clinics. And in the country, we are managing safety, moving from reactive reporting to proactive signal detection. And in the classroom, we are managing trust, training active auditors rather than passive users. Resource limitations are real, but they can be solved by intelligence integration. Next slide, please. So in our research unit, we believe that together we can build the future of pharmacy intelligence. And thank you for your attention, and I welcome any questions. I look forward to future collaboration, and you can find more information about me and our lab at the website at the QR code. Thank you so much, and back to Lars.
Thank you so very much, Kanita, for this interesting presentation and for highlighting how AI and digital technologies, together with the pharmacist's competence, is key today for reaching patients, creating equity, etc. But also, I think the approach towards NCDs is very interesting, as 70% of all deaths in the world are related to NCDs, and also for highlighting the human in the loop, or the pharmacist in the loop as well. So thank you so very much for your presentation. It is now my great honor and pleasure to introduce our second speaker, Dr. Bob van den Berg, lead creative technologist at Deloitte from the Netherlands. Dr. van den Berg has over 10 years of experience as an engineer creating chatbots, voice bots, and digital humans. He is part of the Deloitte team that created the first digital humans for clients in Europe, the Middle East, and Africa. And Bob is passionate about staying up to date on all the latest technologies and implementing them into new use cases. He has worked with multiple Dutch government healthcare agencies and companies to facilitate the use of AI-assisted products. Bob is a frequent public speaker and guest lecturer about conversational AI and Gen AI at the Vrije University in Amsterdam. Welcome, Bob, to give us your presentation on social robots and digital humans, elevating the human experience for patients.
Thank you, Lars-Åke. Excuse my voice, I am a bit sick, but I will now show you a little bit of a short video about one of the first projects that I did at Deloitte. Please continue.
Ik weet van mijn oma dat ze het heel erg vond om alleen te zijn. En ze zocht ook vaak contact met mensen dichtbij in haar buurt. En dit zou misschien een facilitator daarvoor kunnen zijn.
Een paar jaar geleden heeft professor Johan Hoorn van de VU een onderzoek gedaan naar eenzaamheid onder ouderen. En gekeken of robots konden bijdragen aan de oplossing van eenzaamheid en de gevolgen daarvan. In eerste instantie was Alice eigenlijk een pop die van afstand werd bediend, waarmee experimenten konden worden gedaan om te zien of dat een positief effect had op ouderen die alleen wonen. Afgelopen jaar zijn we heel hard aan de slag gegaan om een echte robot te bouwen.
We beginnen echt in co-creatie met de doelgroep. En stap voor stap evolueert het concept eigenlijk met de inzichten mee. Het eerste wat Alice moet doen is een sociale rol innemen, als een sociale entiteit behandeld worden.
Daarom hebben we gekozen voor een sociale robot die enerzijds dat maatje is, maar ook verbindt met anderen. Dus Alice wordt echt de spin in het web van het sociale netwerk van de ouderen en helpt ook een persoon die wat eenzamer is over die drempel om contact te zoeken met anderen.
We zijn vandaag een kort onderzoekje aan het doen over welke vorm Alice zou moeten krijgen. Welke verhoudingen, hoe ze eruit moet gaan zien.
We zijn nu bij Makeversity, samen met Tim. Hij is degene die het prototype maakt. En het model wat ik in mijn handen heb is een 3D geprint model wat hol is, waar alle elektronica ook in past. Alice zal aan het begin heel veel moeten leren, heel veel vragen. En die natuurlijke nieuwsgierigheid die bij kinderen zo acceptabel is, die proberen we eigenlijk ook in Alice te stoppen.
Als je een gesprek wilt hebben als robot zijnde met een persoon, dan wil je ook dat de robot iets van die persoon onthoudt, zodat daarop doorgevraagd kan worden. En dan kan je wat diepere gesprekken gaan maken.
Op dit moment hebben we een team van ruim 20 mensen. En het zijn allerlei disciplines, van softwareontwikkelaars tot onderzoekers. We hebben designers die de buitenkant van Alice ontwerpen, maar die ook de stem van haar ontwerpen en de gesprekken.
Zullen we een raampje open doen?
En verder hebben we ook strategen die nadenken over hoe we de markt gaan betreden. Dus eigenlijk komt hier alles samen wat Deloitte te bieden heeft. En daardoor is het ook echt een soort vlaggenschip project voor Deloitte. Omdat we gewoon laten zien dat we met die enorme organisatie die we zijn, verschrikkelijk veel goeds kunnen doen.
Ik vind het vooral belangrijk dat Alice een soort van maatje wordt, maar ook hulp biedt aan de ouderen bij dingen die ze niet meer zelf kunnen doen. Denk daarbij aan het thermostaat bedienen of boodschappen bestellen of een taxi regelen.
Wat mij fascineert is dat we door nu heel goed na te denken en iets heel moois en heel goeds te ontwikkelen samen met de gebruiker, straks miljoenen mensen kunnen helpen om een veel fijner leven te hebben.
Thank you. So as you just saw in this short video, Alice was a collaboration between the Dutch Vrije Universiteit Amsterdam, roughly translated the Free University. And there was basically a human-computer interaction research project by Johan Horn, as you just saw. And this was called the Alice Project. And a lot of the studies were done by the VU using this robot and by students that took Alice to basically elderly people to see how she interacts. And previously this was done with Wizard of Oz testing. So that is that you have a human behind a keyboard saying what the robot should say. And now we wanted to basically automate the human behind that keyboard away. So that was our goal, and this was well before large language models and the creation of ChatGPT, for example. So one key takeaway that I want to give you is that Johan Horn thought of is the robot brain server. I will talk a little bit about that. Right now, Alice is back at the Free University, and basically they are doing more research with these types of robotics. Next slide, please. So this robot brain server that Johan Horn has talked about is basically a robot brain, right? That has multiple AI models embedded into it. But it also has an architecture that you can take out a certain model, think of, for example, the speech recognition, and replace it with another model. Well, recently we have seen so much computer science and AI research developing also new, very good models, for example, for speech recognition, but also large language models, and maybe also for the displaying of how a face should display emotions during speaking, for example. And that is something that I will talk about a bit later. So it's important to take that into account, and also as you can see here, the robot brain server is also embedded in Alice, but Alice is also connected to all kinds of things. To talk, for example, to friends and family. Maybe Alice will prompt to have a person call their friends and family to mitigate some of that loneliness, for example. or they can help them with calling a caretaker or a care provider. Well, all these kinds of things. That was basically the thought process behind this robot. Next slide, please. So taking that robot brain server also in mind towards digital humans. So back in the day, almost 10 years ago, this Alice project was very big. And after a lot of time of creating chatbots, voice bots, and other kinds of things, we saw a new innovation called the digital humans. Digital humans are basically an evolution on chatbots and voice bots. So they're well integrated within an intuitive user interface, for example. And they have an emotion that can be displayed, and they can move their hands. They could maybe even walk around in a 3D space. And this is all based on game engines, for example, displaying a game avatar and then being optimized for actual use by companies or maybe healthcare providers, for example. And there we can also connect it again to all kinds of things. And to do that, we use something like traditional conversational AI platforms to also prompt when it needs to display a certain emotion or to do certain things, call certain tools. And these traditional conversational AI platforms have also embedded large language model technologies. And that's also where we can set up guardrails and all kinds of things to make the conversation more maintainable for companies, or in this case, pharmacists, for example. So, and these tools could be also data processing. What has the user said? What should I respond? Based on what data do I need to have a profile of this user and know what kind of prescriptions they have, for example. And if you would like to know more about some of this research, you can also scan the QR code. It also includes some research of Almira Osmanovic Tunstrom that happened in Sweden as well. And that was more research around doing human-computer interaction with a digital human as a therapist. Also very interesting in my opinion. So if we can go to the next slide, please. So back in 2022, Kren et al. Basically, they published a paper talking about the amount of papers that were produced and also published on arXiv. And this shows a very exponential reality of the amount of publications. And they also noted that it's harder and harder to find good research or at least keep up to date on for the researchers reviewing these papers also on what is published there. But it also means that there's more and more research in the field. And again, thinking about that robot brain server, it enhances all these models that are still coming out, and we could still take from the digital human, for example, a certain model and enhance it with another model. So this is a little bit the thought process behind this as well. So it's future-proof, if you will. And I recently did another test if this was still the case, this exponential reality. And if we go to the next slide, you can see that there's a small difference here. This is the amount of publications going to arXiv to see if they can get publicized on arXiv. But there's still an exponential increase. So with that in mind, I feel that digital humans are happening. The technology is already there, and there's more research coming out, and they are becoming better. Next slide, please. So at Deloitte, we have already created quite a few digital humans. A few of these clients are displayed here that are more in the healthcare field. For example, Janssen, Region Västra Götaland, Omring in the Netherlands, Pharmi, and Philadelphia. And I would also like to talk a little bit about Pharmi in this case. So if we go to the next slide. So Pharmi is basically a digital pharmacist, right? Trained to help people getting their right medication, and if they have any questions around this, to give certain answers. Unfortunately, this has never really been in production, but this was also, again, well before large language models were a thing. So this is super interesting, still a super interesting use case to build out, in my opinion. And they were really, in front of a lot of the market and with a digital human in mind. And they're still developing as well, Farmi, basically their own platform, and but they're also continuing with digital humans at a later stage, probably. So if we go to the next slide. Basically, what we have built is we used their database of medicines, and we connected it to the digital human to be able to talk about up to 90 medications. Right now, we have seen a lot of development in this AI space. So to be able to give a good answer about certain medications, you would indeed have a certain profile of a user. You could use something called retrieval augmented generation to take some data and embed it in the answer of the digital human. And also to really give a personal feel to the user, right? Because maybe they really want to talk to a human, but this is at least a next level and the next step up. And we have also created a digital human for the Dutch National Police, where they take in a whole police report, and that is now being tested in the Netherlands as well. And these kinds of information is super interesting to automate certain things, right? Next slide, please. So our colleagues in Canada have also created a digital teammate, as they like to say it, for the Ottawa Hospital. One of the first use cases that they wanted to basically create is that this digital teammate would ask certain questions for people that had a heart operation to see how they feel, because every now and then they have to have check-ins, right, with the doctor. And now the digital teammate could take a part of that workload from them. So the digital teammate is called Sophie, and she's currently being built upon further and also implemented at the new Ottawa Hospital. And if you would like to know more, you can find online already quite a few interesting use cases. Next slide, please. So we are partnering with Unique. Unique, in my opinion, has the best digital humans on the market. There are a few other players out there, but I will show you a demo on the next slide. They do also all kinds of implementations with all kinds of clients, and in this case, it was for Maya MD. To really give a face in healthcare to generative AI and these kinds of use cases to help patients, for example. Next slide, please. So I know that the video stream is it's a bit not optimal, but it's a very fluent.
AI technology. Hello. AI technologies and digital humans are changing clinical pharmacy practice in many exciting ways. They help pharmacists make better decisions by providing important information quickly. For example, AI can analyze a lot of data to find the best medicine for a patient based on their needs. Digital humans can also assist patients by answering their questions about medications and health in an easy-to-understand way. This makes it easier for patients to follow their treatment plans and feel more involved in their own care. Overall, these technologies help create a better experience for both pharmacists and patients.
Yeah, so this was a short demo of one of the digital humans that I very quickly set up. And I prompted her to give some information, for example. And this is how it looks right now. And what we basically do is we tailor the whole interface. We make sure that the interaction with the digital human goes very fluently, that there's some processing time, that the digital human is thinking, for example, that the user can speak. And maybe it can also do something in 3D. So think of that it shows how to inject the EpiPen, for example. So it can also do things in 3D, right, that we define in this 3D space in the game engine. So this is just an example. Next slide, please. So here we have one more talk about biases and stereotypes. I don't really have a lot of time to, we don't have to play it. You can simply go to it on the QR code, I would say. So this is a colleague of mine that is now working in Sweden. And she also gave a talk about biases and stereotypes about these kinds of digital humans that we have created together with her, and how these kinds of interactions exist. But I don't really have time to go deep into that right now. So, well, next slide, please. Thanks for attending. If you have any questions, you can always reach out to me. And I would say back to Lars-Åke.
Yes, we seem to have some technical problems, but I think you can hear me now. Is that possible?
Yes.
Excellent. So thank you so very much, Bob, for your very interesting presentation. I think it's really exciting how digital humans actually can support patients in many different ways, and also for you can say daily tasks. But of course, linked to pharmacy and how they can support the pharmacist in providing better care for our patients is really, really exciting. And also how this exponential development in research actually is empowering these avatars or digital humans to provide even better support, and as well becoming future proofed, as you can say. So very interesting. Thank you so very much. It is now my great honor and pleasure to introduce our third speaker, Dr. Tora Hammar, Associate Professor in Health Informatics, eHealth Institute, Linnaeus University in Sweden. Tora is an associate professor and senior lecturer in health informatics with a research focus on medications. She is a licensed pharmacist and holds a master's degree and PhD in biomedical science. And Tora serves as executive director of the eHealth Institute in Sweden and is the coordinator of the eHealth group within the Linnaeus University Center for Data Intensive Sciences and Applications. And she is also a scientific coordinator for collaboration for eHealth in Sweden. Her work spans research, education, and collaboration with a strong emphasis on advancing digital solutions for healthcare and medication use. Welcome, Tora, to give us your presentation on AI-assisted clinical decision-making for improved medication safety.
Thank you, Lars. I'm honored to be here, and thank you for that nice introduction. I will just see so I can, So I'm right now sitting in Sweden. That's where I have my office. It's in the southern part of Sweden, and we have snow and cold outside. And this is my view with the castle in Kalmar. I work at like Lars said, I work at the eHealth Institute. That's a part of Linnaeus University. And we started already in 2002 working with eHealth and digital health. And we are what we call an interdisciplinary academic environment that is a part of shaping the future of digital health. So we work with both research, education, and collaboration in this field. And I will move forward to the topic of today. So what we have right now, we have a lot of valuable data from healthcare, from sensors, from registers, and from patients tracking things in apps and watches and things like that. So we have a lot of data, but what we want is to transform that to information, because data on its own doesn't say so much. And from information, we want to have knowledge and wisdom. And in the end, we want to be able to use this to inform our decisions. And that is not always a simple task, but it's one of the things that I'm working with. So in this field of medications that I have my focus on, I want to describe to you 2 different projects where we move from data to decisions and how AI can help. But first, before I go into the projects, I want to give you some background to this. So AI, you've heard a lot already. With this, I refer to systems that simulate human intelligence to perform tasks like learning, reasoning, and decision making. And I think that digitalization and also AI is very important to manage the global challenges that we have with the aging population and limited resources, lack of healthcare professionals and competence, and many other things. And in the field of medications, you can see already that AI can be used for everything from like drug development to pharmacovigilance, decision support systems, and many other things like patient support. And yeah, the list can go on and on, but I will focus on parts of this. Before I talk more about, the possibilities and what we look at, I think that one thing that is always important to highlight is also the challenges with digitalization, AI, and the health data, because it's not, if it would be easy, we would already have all the solutions. So it's good to also be aware of why is it a bit difficult in this field. And of course, I will not go, I can talk for hours about these things. It's one of the things that we teach a lot about, but I just want to mention that what makes this field specific is, of course, that we need to think about patient safety and also the ethical and legal aspects. And here we have a kind of rapid change with the legal parts with this. And another thing is that we need a good quality assurance and evaluation of things that we want to use in connection with patients. We also need to think about the implementation. We can have a good AI solution, but if we don't have a good process of implementing this in clinical practice or in pharmacies, for example, maybe it will not be used or not in the way that we want. Another big challenge that I want to highlight here is the thing with interoperability. It's when we have many different systems. It's we need information to move between the different systems, but often we have different structures and both limitations with technology, but also information structure that makes it difficult to just share information between the different systems. So this gives a big challenge for just both AI solutions, but also in the clinical practice. And the data in itself is quite challenging with both structured and unstructured formats, and I will come back to that in our research. And with AI solutions, we also need to think about, the transparency and the reliability so that the users can rely on them and still take responsibility of decisions, for example. We need new ways of working. The responsibility is a tricky question. Who is responsible for the decisions being made with support of AI, but also decisions about how to use AI and things like that. One difference between, if we talk about medications that can be developed in one country and then you can use it in other countries, with technical solutions, specifically AI, there is difficulties in generalizing the results. So you cannot only just take a solution from Sweden, for example, and then use it in another country without doing some work with that. So that can be challenges. Another challenge is the competence, and that is why we need things like this, that we talk about AI and we raise the competence in this field. I want to give one my view on the difference between when we talk about decision support, the difference between what we call expert systems, like many of the systems we have today, and also when we talk more about AI and machine learning. So when we have an expert system, and this, you can call it many different things, but here I talk about when we have predefined rules, often written by humans, based on expert knowledge and scientific publications, and you have that in the decision support. So often that is built up by a knowledge database from humans and some kind of decision engine. And that requires often kind of a manual update. And this is many of the decision support we have today. I will show you examples of that. And I mean, the benefits, and they can have a good quality. And one of the strengths is that this is very transparent and predictable. You know, I mean, the alerts that you will get in a decision support, and it's easy to validate. But if we instead talk about, I mean, AI and machine learning, if we want to have decision support using that, we, instead of programming specific rules, we instead have models trained on the data to learn to solve a task without like programming with specific rules from humans. So the benefits here is that we can handle more complex data than in the rules that we write ourselves. But one of the major drawbacks and challenges is that what we call about like a black box, that sometimes it's difficult to understand the reasoning. Why do I get this recommendation or this alert? Can I base my decision on that? And yeah, so that is something that we work a lot on in the field of AI and decision support, to make it more transparent and have explainable AI. And I will come back to this in our research, because we are looking at both of these solutions. So just an example from Sweden, and I think that many of you working with medications in pharmacy in the different places, you're quite familiar with the traditional drug-drug interaction databases, that you can have a decision support that can give a warning if you have two medications, two substances that can have an interaction. So you have pairs of medications that interact with each other and that you can avoid or keep track of in different ways. So we have one of these systems in Sweden, and we use it both in pharmacies and in healthcare. But if you think about a situation where we have a patient with like 5, 10, or 15 different medications, maybe it's not enough to just look at these pairs of interactions. You want to look broader. Then we also have another decision support in Sweden that looks at more the pharmacodynamic interactions and look at all of these connected with each other. I haven't been a part of developing this, but we look more at this system in my research. So I just wanted to show you an example of this. So here we have all of the different medication substances that we have in Sweden have like a risk classification for 9 different common or serious side effects. So it can be like constipation, sedation, risk of bleeding, QT prolongation, and things like that. So for each medication, you get on that level classification that, okay, so this morphine, it doesn't increase the risk of bleeding, but this other medication, you have an increased risk of bleeding. On a patient level, where you have all of these different medications, you can then see that, okay, so this patient, she has 3 different medications that will all increase the risk of sedation. So even if it's not a traditional drug-drug interaction, we can have like an increased risk of these side effects. So this is one way of looking at this, and this is available not everywhere in Sweden, but this is available like this traditional rule-based decision support. But in our research, we want to look at, or we have been looking at, both this system and the previous traditional drug-drug interaction to see how relevant are these warnings, and I will explain why. Because even if you have a high quality knowledge database and very good experts working with this, there are challenges with the decision support we have today. that we know that many of these alerts are not clinically relevant. So you get a lot of warnings for patients. So if you are a doctor, for example, or a pharmacist, you get maybe many warnings for the patients. And that can then result in an alert fatigue and then in alert override, so that you will not follow the warnings. You will maybe not even look at the warnings when they come up, because some doctors that I talk to say like, oh, that one, it's always red for me, so I don't even look at that because it's like warnings all the time. And you can see in the scientific literature that, I mean, for many decision support being used around the world, you have like alert override more than 90% for some of them. So that, I mean, the majority of alerts are ignored, and then you can maybe miss the really important alerts, and then you will have still the adverse drug events. So this is why we need the validation of these and how we can improve them and validate it in real world data to improve predictions. And here we are curious if AI can be used to reduce alert fatigue. So just to give you an example, if we want to use AI to reduce alert fatigue, or machine learning, a type of AI, you can do this. There are different ways, but I want to show you two different approaches to just highlight that this is not just a simple thing. You always need to look at what is it that AI is doing and trying to understand that. So two different approaches. One way is that you can use data on how healthcare professionals act on the alerts, and then you use that data to train models to predict which alerts are usually ignored, and then you can improve alert fatigue by learning a model to like filter out those warnings that are usually ignored. And that is one way of doing it, and there are some research, but there are some weaknesses with that. I mean, you can never have something that is better than the healthcare professionals today and things like that. The other approach that is still the same basic aim of this is that you instead use data on clinical outcomes. You look at what is really happening with the patients, and then you train the model with that data to predict which patients have the highest risk of these adverse drug events. And that is what we are doing in the research that I lead. So in this project, we look at several things. We want to learn more about risks when combining many different medications. And then we want to understand how well does the current decision support systems predict adverse drug events. And then in the final step, we want to improve predictions by using machine learning. And I will just shortly explain that. And then we have, from this, we have another small project that I will talk about in the end, where we also want to look at the clinical notes, the free text. But back to that quite soon. And I will do this quite quickly because I see that my time is running out. So the data that we use in this project, we have from the region in Sweden where I live and have my research in the region of Kalmar. So we have actually 13 years of data now. So from 2010 to 2023, we have data from the electronic health record. So we have all of the medications that are being dispensed or given at the hospitals. We have diagnosis and other clinical outcomes for the patients. So we have a lot of data. And we also have access, or we use the current knowledge databases. I mean, the algorithms from the decision support we have in Sweden today to help us in this. And what we have done several studies in different populations where we try to, describe what are the potential adverse drug events that we find with the decision support algorithms. But then the maybe more exciting part is where we look at how well does the current decision support algorithm predict actual clinical outcomes. And we do this in several different studies with different designs, and I will not go into the details. If you're curious, you are more than welcome to contact me afterward. But we have done this, for example, we have looked specifically at patients that get medications where, according to the decision support, they have an increased risk of QT prolongation. And also in another study, we look the same way with an increased risk of bleeding and anticholinergic side effects. And then for each of these studies, we follow the patients for 1 year, and we look at will the patient have any of these side effects that we are afraid that they will get based on the decision support knowledge database. So, and we also have another study where we look at patients that are admitted to hospitals via the emergency department. And then we look at the medications in the time before that, and we see, I mean, were there signals from the current decision support that maybe could have helped us to prevent this, and how well did that align with that? So based on those studies, I mean, really short, we see that we see a clear association between the risk classification from the current decision support and clinical events in the patients that indicate adverse drug events. So we see, I mean, there is an association between this. And we see also that if you have the highest risk level, you have, I mean, the highest risk of actually having a clinical event. But we also see that there are many factors involved. And in the traditional decision support that we look at today, that we have in Sweden, those systems only look at the medications. So you see, you don't put in any other factors from the patients. But in our models or in these studies, we see that many other factors are involved and could actually be part of improving the decisions. So from that, we conclude that we need to improve the predictions to reduce alert fatigue. And that is where we move into the machine learning and AI that we are working right now, and will do many studies this year. And as you remember, I said that we use like the clinical outcomes to train the models. And just and the difference is that in these models we do not only use, of course, the medications. We use other patient factors like previous diagnosis, like age, gender, many other things that could affect the risk of having these adverse drug events. So to understand this, and our preliminary results from the different studies show that yes, we can absolutely improve the predictions compared with the decision support we have today with machine learning models, where we incorporate more factors. So we have a good potential here. But I want to highlight that in all of these studies, it's really essential to us that have this like critical and the reflective approach when considering AI solutions and models, and to really understand that, okay, this model, it can predict better, but what is the model based on? And is that a reasonable way? So we really try to dig into this. And as I mentioned, there are many barriers and challenges in implementing AI in healthcare. So we have actually looked at like a maybe simple solution. We use the knowledge that we have from the AI models, and then we transform it back to more like the rule-based model, but where we put in other factors that are not only medications. And here we have really promising results as well, that we can perform almost as well as the machine learning models, but those would be much easier to implement in healthcare and pharmacies or wherever we want them. So just to, I mean, this project is really exciting, but there are many challenges with the data I mean, the conclusions we can draw from it, but it's really nice to be able to use the data in this way. One of the things that we realized quite early in this project is that we have a lot of valuable information in free text as well, because what I talked about now is only the data that is in structured format, like the diagnose codes and the medications. So that is why we started this parallel project where we also want to develop methods to detect adverse drug events in clinical notes using large language models. And I see that I will only have like 1 minute left, so I will just really shortly say something about this. That I think that you are well aware of a branch of AI with this natural language processing, and that is what we can use to be able to also find data in the free text. And you've heard of, I mean, we have the spontaneous reporting of adverse drug reactions and adverse drug events, but we know that many things are not reported, and many things are not put into diagnose codes. They are only maybe written by the doctor in free text. So that is what we want to find and to be able to use in research and to understand this. So we have developed methods with data from geriatric patients, also here in Kalmar. And to summarize, we have some really exciting results here as well, where we can improve this, because we see that before this research, the methods weren't good enough. We are not near any final results here as well, but we see really good potential that we could develop methods to be able to find these adverse drug events, and then also to use them in, for example, machine learning models, so to better understand adverse drug events. And and we have many thoughts of how to develop this even better from the first tries that we have done. Of course, I have not done this on my own. I'm the leader of this project, but I have a lot of researchers with me from both pharmacy, but also computer science. So we work really closely together, and that is, I would say, the key to this kind of projects, with the interdisciplinary collaboration. So my final slide is if I think it's possible to enhance medication safety with AI and health data. And I think absolutely, but that there is much left to improve and many challenges that we see in our project. And don't forget the interdisciplinary collaboration. We are fantastic as pharmacists, but we need to collaborate also with other people. So thank you for listening. And sorry for taking an extra minute, Lars-Åke. Thank you.
Thank you so very much, Tora, for this very interesting presentation as well, highlighting both the challenges with digitalization, AI, and health data, as well as sharing the value of some AI tools, and also for showing some very interesting research projects. And as your final slide, the critical approach is also very important, and of course, the interdisciplinary collaboration, because everything is nowadays about collaboration. So now I would like to ask our three fantastic speakers to turn on your cameras for a Q&A session. And to all of you listening, please submit your questions via the Q&A tool at the bottom of your screen. We have quite many different questions, so I will start at once. Actually, I think I will start with you, Tora. Can we apply AI in pharmacogenomics as well? What do you think?
I mean, the easy question is yes. I think that absolutely. But as in everything, we need to do it in a careful way and to really understand what we are doing.
Yes. Okay. Yeah. To our fabulous speaker from Thailand, you mentioned the electronic health records, etc. Are these interoperable, and how do you obtain data for research?
That's a big question. I think it's a challenge everywhere about the data interoperability, because like even in Thailand, each hospital, they have their like unique databases, they have unique data type, they have unique like medicine codes and everything. However, in Thailand, now we are trying to walk like baby step, and one of our big data institute agency in Thailand, we're trying to create a project we call it Health Link. And that health link, we will try to make these data from separated database to be interoperable together, so that we can train, we can use the data like in so many ways. And another one thing that I've seen it lately here in Thailand, that big hospital like university hospital, we try to establish data innovation center. Like actually next week we'll have a conference in data innovation center in Bangkok, and a lot of medical school, we will like we will talk together, we will collaborate together on the data innovation. So we're trying to break the barrier of data interoperability by doing data engineering and data innovation. So we will de-identification of all of the data sets, the privacy things that we will not include it, but we will innovate the data engineering. And then I think somehow we can share those data across the hospital together. And that's the way to move forward. I mean, like in Thailand context. We are doing it though. It is not like really completed, but we are doing it like right now. So that's about the data interoperability. But right now, for my research, I will work on like only one institutional. So I will only have the data in like single setting, in one setting. Like if I doing a research with the Thai FDA, I will only have a data from Thai FDA only. I cannot like use the data from somewhere else. So that is my limitations on the research too.
Thank you
Yeah.
so very much. Over to you, Bob. When using all these digital humans, how can pharmacists ensure patient safety, evidence-based practice, and professional accountability when using AI in clinical decision making? And how can this digital human support the pharmacist, would you say?
Yeah, I think what is important is that the digital human first handles all the low-hanging fruit, if you will. And if there are certain things that the digital human can't handle or should not be able to handle, right? Because maybe it shouldn't be prescribing something to someone. You can always do a handover, for example, in a video call. So a digital human can easily be connected to a Microsoft Teams solution, for example, and then connected to a real pharmacist. So those are, I think, some ways that you could mitigate that it talks about use cases that it shouldn't talk about. But also enabling those use cases will take iterative work and solution design, to enhance what the digital human can and cannot talk about, for example. And also it should really be monitored what the digital human is, for example, saying. And like I said before during the presentation, we should use like a conversational AI platform to really create these kinds of things that the digital human can talk about. Basically creating barriers for what it shouldn't talk about.
Okay,
Hope
yes.
that answers.
Thank you so very much. We also had a question here, a general question, if FIP staff members are willing to work with developing countries to conduct pilot studies of AI integration into pharmacy practice, and also assist young pharmacist developers who wish to design AI assistants. Well, actually, the easy answer is actually to contact your member organization in your country and ask for a support from FIP for a project. FIP never goes into a country without the sort of permission from our member organizations. So please contact them, and then they can actually contact FIP headquarters and find relevant people within our organization or the headquarters or the FIP Technology Advisory Group to support you in your research projects. Tora, here is a question for you. How do you balance the peculiarity of medications across race and nations with AI, both for different drug classes like hypertensives, etc. Do you have an answer on that one?
No, what I can say that it's, of course, it's really important. I mean, the data that we use to train AI models will then, I mean, affect the result that we get. So it's really important that we use data from different populations to get a good overview of how it will work. So that is one of the challenges in, like, if I only, like now I have only been working with Swedish data. And for example, yeah, of course, we have some differences between, I mean, people in the Swedish population as well, but it's good to also validate in other populations, I would say. So the important thing is to use data and to be aware of the data that you are using, because that will introduce bias and challenges with the AI model.
Yeah.
But I don't have a really good solution in this. But what I can say is that, of course, if you use real world data, I mean, from the population, that will reflect that. So that is maybe one step better than what you get in like a randomized controlled trial, where you have really strict inclusion criteria and things like that.
Yes. Okay. Thank you so very much. Kanita, in your experience, what is the most effective way for pharmacists to communicate a high-risk score to attending physician without overstepping?
Oh, okay. Well, that is a very challenging question, very difficult to answer. But like in my experience, we don't really like overstep the physicians. So we trying to make kind of like a signal, kind of like alerts. Like for our project, we will highlight the patient as like a green patient, yellow patient, and red patient before they enter to the clinics. And then the physician will notice that, okay, so this patient is kind of like a moderate risk, or this one high risk, and we will not really recommend what they need to do, but we will just notice them that this is a moderate the risk patient, this is high risk patient, and it's all up to them to decide whether if they want to switch to other medications, or even if they want to order like additional EF measurements or something like that, doing more echocardiograms or something like that. That will be up to them to decide. But we will just like mark that patient has a moderate risk, that patient has a high risk or something like that. That's what we do. And that maybe help to prevent overstep the physicians.
Okay. Another follow-up question regarding your country. Is the use of AI within healthcare and pharmacy regulated on a national level?
Can you repeat the questions again?
Yeah. In your country, Thailand, is the use of AI and different models for healthcare and pharmacy regulated on a national level? Do you have a regulation how to use these tools?
Yes. Right now, actually, this is one of another project that I work with Thai FDA also. The regulation is actually there. Right now, we have regulation for software as a medical device. So we use that one, but we still hit some of the bottleneck along the way for the regulatory approval process. And we are trying to do gap analysis and working on that. Hopefully we can accomplish that within like 1 or 2 years, that we will have like all the complete regulatory. But as of now, yes, every software as a medical device, all of the AI tools that will be used in a hospital, they need to get approval from the Thai FDA.
Okay, thank you so very much. Bob, regarding the digital human, what are the quadrails put in place to ensure the user privacy? How is data collected, and how actually do you handle user privacy?
Yeah, I partly also answered this in the answers, but the robot brain server should be able to live on premises on one computer without an internet connection, basically. And that is also what we do with the digital human and with Alice beforehand. For Alice in the research phase, we were really thinking about, okay, right now we will use a certain cloud solution, but then we will migrate that back to the computer that's basically running the robot. And the same actually goes for the digital human. So Unique has a solution that can be deployed on premises, on your own servers or your own server park even. If you have a big solution needed. But also I have it installed on one of my computers at home. And it's completely running locally, rendering digital human in 4K with all the emotions and the voice and the speech recognition. And you can then serve that to a client side somewhere else where, yeah, for example, at a pharmacy. And in that sense, you really enable the digital human to keep all the data to itself. And if admin needs to look at it or a pharmacist needs to look at it, you can give access to them.
Okay, thank you so very much. Now over to you, Tora. We have a question here whether in all these research projects, are pharmacists in Sweden involved in those projects and how?
Yeah, they're very much involved. So I've done specific research projects on the decision support used by pharmacists on the community pharmacies. But in these projects that I talked about here, it's more that part of our team consists of pharmacists. I will say that that's the most common thing, that you are a pharmacist. So those are very much a part of this, and it's good collaboration. We also have doctors and like computer scientists, but pharmacists are really important in this.
Okay, thank you so very much. That's very good. Very nice to hear. Kanita, your findings on specialist fallacy are, one can say, quite alarming, specifically that the specialized medical AI performed worse than the general one. What do you think Perceptor AI, why do you think Perceptor AI failed in compounding tasks, and what is the takeaway for pharmacists using these tools?
Yes, thank you. That's the one of the challenging of developing specific AI to do some specific task. Actually, I wouldn't say only Preceptor AI, but maybe some other medical related AI can face the same issue, because the core of this issue lies in like how these models are built. Because actually the specialized large language model would train on a narrower and highly specific sets of sources. Like for the medical assisted AI, they will be highly trained in the medical data sets, medical guidelines and textbooks and stuff. So it may like sound authoritative, but it also make the model more rigid. So some of the easy or general healthcare question, they cannot answer it well, because these AI, they lack a broad knowledge. Like for general tasks like compounding that require like a basic knowledge, they cannot really answer it well. Maybe because they don't have enough knowledge about compounding within this specific AI. But when we ask ChatGPT or maybe Gemini, they might be answer it better, because they might know like this sort of knowledge already. So I would say that the takeaway is that medical label often imply a depth of knowledge that somehow isn't there. And a specialized tool may be safer for a standard guideline check, but for the complex reasoning or maybe general question, it probably lack of flexibility that we need. So that's why I think we need a pharmacist in the loop.
Excellent. Yes.
In order to use this type of AI.
Yes. Over to you, Bob, again. What barriers do we need to address for a safe adoption of the digital humans in healthcare and supporting pharmacists as well?
So what barriers?
Yeah, do we need to address?
Well, first of all, you can't just simply put a large language model there, right? And also, as I also explained earlier, these conversational AI platforms, you can really tailor what kind of way a certain conversation should be going. What we see, for example, if you add more and more tools to a large language model, it becomes less reliably answering all kinds of things with the right tools. So you need to keep those, basically agents small to be able to handle multiple use cases. And you can do that using such a conversational AI platform. I think another barrier, the user interface should just be very intuitive. There should be really a good UX design and also the creation of the digital human and the interface together with the clients, for example, is something that needs to be tested very well. And I think, I'm not sure how many barriers there still are because connecting a certain data set to a digital human is quite easily doable, I think, already. It's a matter of doing, in my opinion. But we will find the barriers when we get there and solve them, in my opinion.
Yes, thank you. Yes, I think you are right, and you said that in your presentation as well. Co-creating with the patients or the users. I think it's really important because the patients or the users actually provide us with a lot of data. So it's also to a large degree about trust. So they trust us, and of course we need to respond to that. So by that, I think I will give you all the same question, and it was also put in the Q&A box. Will AI replace the pharmacist? What do you think, Tora?
No, I think that the future is us collaborating with AI.
Okay. What do you think, Anita?
I actually answer in the box. AI will not replace pharmacists now or never. AI will allow pharmacists to free up more workload, and that will make us have more time to spend with patients, and that we actually matter. That is actually matter. Yes.
Yes. Thank you. Over to you, Bob.
Yeah, I completely agree with both. There are some use cases that we want to prevent from being used by AI models also on a regulatory level. But I don't see, I see that some of the repetitive tasks will mostly be, automated. And I think that not all of the users will want to use AI, right? So there is definitely a need for pharmacists, but maybe their jobs will also change a little bit in terms of doing less repetitive tasks and also helping maybe see if all the AI models have done correct work and next to their job that they currently have, of course.
Yes, I agree with you all. And also looking to the future, 1 or 2 decades ahead, we will actually see quite many new professional roles for pharmacy and pharmacists. And that also puts pressure on our educational instances, you can say, our universities and faculties of pharmacy, because this is an exponential development and we need to prepare today's pharmacists for tomorrow's work already today. So let's now look at the final slides, ISO. Yes. Today's session, I think, has clearly shown that artificial intelligence is no longer theoretical in pharmacy practice. It is already shaping how we manage risk, how we connect with patients, and how we actually protect medication safety. And we have seen how AI can support pharmacist-led decisions from the individual patient level right through the system-wide monitoring. And we have also been reminded that technology, including social robots and digital humans, can strengthen, not replace, the human experience in care. And finally, we have also seen how AI-assisted clinical decision-making can help us deliver safer, more effective medication use in increasingly complex clinical environments. And AI doesn't diminish the role of the pharmacist. It amplifies it. And our clinical judgment, ethical responsibility, and patient-centered values remain essential. But as pharmacists, we are not just users of AI. We are actually also leaders in how to apply it in pharmacy practice. And if we embrace, I think, these tools thoughtfully and responsibly, we have a real opportunity to shape safer systems, more meaningful patient interactions, and better outcomes for the patients we serve. So let's look at the next slide. I would say once again a big thank you to our excellent speakers for sharing your experience, wisdom, and knowledge in this very exciting area. And I advise you all to check out all future FIP digital events at events.fip.org. And here you can also see all the recorded sessions before. And I would also like to take this opportunity to invite you all to the World Congress of Pharmacy and Pharmaceutical Sciences in Montreal, August 30 to 2nd of September this year. The theme for the Congress is One Health, One Pharmacy, Bridging Science, Practice and Education. And discussions will examine actually how pharmacists can drive progress towards better health outcomes, equitable access to essential medicines, and resilient health systems worldwide. And here you can see the 3 tracks of the Congress. And I can assure you, I have seen the program, and I can assure you that it will be a super exciting event. So I hope to meet all of you there. So once again, thank you all for attending. A big thank you to our fabulous speakers, and a big thank you to Aisu and Albina and our colleagues at FIP headquarters for, as always, excellent support. And by this, I thank you so very much for attending, and I wish you a great day. Thank you so very much, and goodbye.